condition to do this. Okay, so next. So when I remove the tooth, do I raise the flap? So I go back to the literature and it says that if I extract the tooth without raising the flap, I actually reduce the bone loss in the initial phase. However, if I wait long enough, which is like delayed placement, it makes no difference if I raise the flap or not. So back to the question, do I raise the flap or not in this case? So it goes down to, again, the basic. So whether I raise a flap or not when I extract the teeth will be dependent on local factors when I see the patient. So in this patient, I see there is a loss of buccal bone, possibly through the cone beam CT, and there is also some soft tissue loss. So what do I do? Do I raise the flap? So I would think that there will be three scenarios when we are doing a socket extraction socket. There will be one where, in this case, there will be an intact bone wall. And in cases like that, we'll usually just do a flapless alveolar ridge preservation because there is actually wall around. But I think in this particular case, when I look at the cone beam CT, it's very likely that there is a big dehiscence. Yeah. So for me, big dehiscence would mean that I will most likely raise the flap. So after analyzing the situation and based on what I see in the evidence, I have decided that for this case, to optimize and maximize the good aesthetic outcome, it will be delayed placement for me. And before the extraction, what I've decided it will be extraction with an open flap, alveolar preservation. The reason for that is so that I can preserve the soft tissue as well as the hard tissue. And I'll go for the conventional method of waiting for 6 months, after which stage 2 and then the final restoration. So I have this case which is rather similar, but it's on the adjacent tooth, which is actually on the 1-1. This tooth also have external resorption. It is pri-RCD and the patient is rather young. The only difference between this case and the one that OV presented is the soft tissue here is rather favorable. It doesn't have the recession like the adjacent tooth. So in this case, when we decided that it will be an open flap ridge preservation because there is actually no bone on the buccal surface through the cone beam CD. And as you can see, there's external root resorption here, and then this all are soft tissue. So after removal, what we see is a big loss of the buccal labial bone wall. There's actually no labial bone wall at all. And this patient, it's a lady, a very young lady, and she is have high aesthetic concerns as well. So what we did was we grafted it with BioOs and BioGuide, and then we achieved primary closure. And this is after a 6 months wait. So we managed to preserve the bone, and you have a very nice scallop bone here. The bone quality is pretty hard. Maybe for me to get back to it, it's besides BioOs, I actually harvested from the nasal spine. So it's a mixture of autogenous and the BioOs. And this is the ridge width, which is very nice at 6 months. And following which we'll be able to put the implant in a very nice position. And this is the final restoration. We managed to keep the gingival margin as almost where it was before. There was very minimal loss of the gingival margin. So with that, I would like to conclude that the reason why I chose alveolar ridge preservation and delayed placement for this case is because it gives me the predictable results I need. And it gives me the long-term survival result that's superior, and there is lower risk of implant failure. However, it should be noted that, of course, this whole procedure takes a longer time compared to the immediate or the early placement, and there's a need for interim restoration which the patient needs to agree upon. And of course, there's more surgical procedures compared to the other two techniques. But like I said, I work as a periodontist, so my patient comes to me all the time. So if I have a problem, the patient is stuck with me for life. So I usually go for something predictable and less risk. So I'm risk adverse. Okay, with that, I will leave you to continue.
Thank you, Marci. Yeah, I'm not too sure whether there are more surgical options in your situation, but nevertheless, we will come to Q&A later on. I think we press on and
can I interrupt with another poll, because after all this, I just would like to see the attendees. What do they think? Do they change their mind? It's quite interesting. Just 2 minutes, okay?
Okay, go ahead.
Okay, same questions. All right. So after you listen to all the panelists, what will you choose? All right, 2 minutes.
I think they're gonna choose early placement.
No, they're going to choose the bridge. They're going to say this is way too complicated. I'll go for bridge. Or I refer this to Dr. Yip to Dr. Lam or something like that. Right? Interestingly, now it's about 40% answer. Keep coming. And there's some questions in the Q&A box. Okay, so if the attendees would like to see some questions, you can go there, and some of the questions have been answered from our panelists already. There's some open questions. There's one open question left, which I think Dr. Obi will present his case, and that might answer these open questions. All right. So now it's about 60% voted. Well, I'm not going to tell you the result yet, but it's quite interesting. I should put the bridge as another option.
How many percent?
Now it's 61%, okay? 62.
How many percent? First poll.
First poll is about 70%. Let me check first. Let me take a look first. I could not remember when I take some pictures. The first poll is, oh, I did not take pictures. Sorry. About 75%, I believe. Now 64%. All right, and I will end the poll in 10 seconds. All right. So if you did not make your choice, please make it right now. Okay, so I will end the poll right now. And the result is, well,
I get more votes.
Yes. Wanjing, you won.
Yes, that is very interesting.
Yeah, it's quite interesting. You see, immediate implant placement is still the same number, but early implant placement is dropping a little bit, but delay placement is coming up. All right, so Gibbs, let's continue with your job. Okay.
Professor Buza is not happy.
That's very interesting. Thank you very much for taking part in our poll. And we press on. And Obi, Dr. Pierre, Dr. Pranay. Dr. Pranay, your name on the screen is Dr. Pierre.
Oh.
Okay, so it's actually Dr. Pranay, and Dr. Pranay is going to speak now on the treatment that is done by the faculty. Yeah, go ahead.
Thank you, Dr. Yu. So I hope I can shift the poll a little bit more, because unfortunately I'm on the 4% side, which is immediate implant placement. We'll see how the results go. So as Dr. Lam, Dr. Melissa, and Dr. Chang's mentioned, we have placement timing, and the difficulty, just like Dr. Melissa said, immediate implant is very difficult, whereas it gets easier and easier if you go to early and go too late. Now, however, the timing and the number of surgery increase if you go to early and late. And for the aesthetics is the key, because it's a front tooth. So with the immediate, the literature said there's more recession in the mid-buccal, whereas early and delay, there's a chance of IDP, the papilla loss. But if you take a closer look, the mid-buccal recession is already happened with early and late. So for me, implant placement is more like trying to preserve how we can preserve the structure that we have. Whereas for early and late, it's more like how do we recreate them. So today I will give you some of my experience of how to preserve them. So Dr. Melissa and Dr. Lam already mentioned there are safe way to do an immediate implant placement, which first we have to have an intact buccal bone, but as Pierre, we don't. There's some defect on the buccal. In the bone sounding, we have a deep, narrow pocket on the buccal bone. So let's take a look at some of the literature by Dr. Khan. He reviewed that, if we do a bone sounding and there is a deep, narrow pocket, we call it a V-shaped defect. Now, if the defect increase just only on the buccal aspect of test 2, we call it a U-shaped defect. And if it extends to the adjacent tooth, then it's called an ultra U defect. Now, with all this criteria, after a year, how much recession does? If it's more than 1.5 millimeter, we have 8.3% for V-shaped defect and 42, almost half for a U-shaped defect, and for ultra U is 100%. So for our case, it's a very low chance, 8.3%. Now move on. For the second one is thick gingival type. For our case, not so thick, not so thin. It's probably somewhere middle there. The probe show barely a little. Now the next one, no acute infection. Our case have no acute infection. It's only. And last one, just like Dr. Lam said, we need to have a sufficient apical and palatal portion of the extraction site, which in our case we have tremendous. We have so much. So I'm going to try to challenge immediate implant procedure. So me and Pierre, what we did is we have the end in mind. This is the beginning. Now we have the end in mind. What we try to do is we try to do everything digital. We do intraoral scanning. Then we put our planning into digital. And this is what we're aiming to get. And with this, we plan our implant position according to what we plan. For the implant position, it's related to the future, where the future geo margin is going to be. And that we have what's called 3D implant position, which there's the vertical depth and horizontal depth. If you look at Landon Cooper, it's a 3 by 2. It's a 3 by 2. So with the immediate implant placement, it's going to be a little deeper and more powerful. So go to about 3 millimeters to the palatal. Two things, which is the key, which are reduced diameter implants and a jumping gap. There are two things. So with a reduced diameter, you create more gaps for your bone graft, for your soft tissue at grade. If you look at the literature between grafting and non-grafting, the lower last two are the two key person that do an implant placement on the extraction site. If you don't graft, you have about almost 4 millimeters of bone resorption. Whereas even if you put graft, you still have resorption, but it's less. It's 1.5 millimeters. You still have that resorption. So how do we minimize that resorption? How do we compensate it? Is to put another graft in. Now, again, another article from Dr. Khan. For grafting, if you don't put a bone graft, you have 69% that there's going to be recession on the mid buckle. If you put a bone graft in there, you have a 30% risk. Now, on the other hand, if you put bone graft and soft tissue graft, you have 1.5 millimeters. You have 6% of the recession. So with that, we plan to do an immediate implant placement with a bone grafting and a soft tissue grafting. So after we plan where the implant is going to be, we create a model. And from that model, we create a provisional. And that provisional actually created beforehand with 3Shape Implant Studio, even before implant was placed. But the key thing that you have to keep in mind is that you have to create a notch on the buccal side of your surgical guide, so that will be the key for your timing, for the implant timing, the notch, where the notch will be. So let's go back to our patient. We did minimum traumatic extraction. After the extraction, we drill and try in the surgical guide. Then one thing that you have to keep in mind that when you place the mounting, there's a chance that you don't place it correctly. The implant might go too deep and the timing might be incorrect. For example, the left one is the correct one, the right one is the incorrect one. And see the line and the notch? When you place the implant with your surgical guide, make sure that it's aligned. So you have the correct vertical depth and correct timing as well. This is what you want to see in your after the surgery. So with that, we perform a soft tissue graft and bone grafting. Sorry, I don't have the picture for that, but this is what we have at the end. So this is right after post-op. This is the X-ray of the post-op. Then we wait. We ask the patient to come back 2 weeks later, and unfortunately, complication happened. Always, for the case that you want to use to present, there is always complication that happen. I don't know why. It might be just only me, but always this happened. What we have was 2 weeks later, we have this. Look like a pus, look weird. We took x-rays, everything looks okay. So let's look at other patients. What do we usually see at 2 weeks? So this is a similar case. We put bone graft in there, we put a soft tissue graft, we send the patients home. 2 weeks later, this is what we usually see. Very nice, almost perfect. You don't barely see any surgical happen. And 3 months, this is what you want to see. But for our case, it doesn't look the same. It looks puffy. It looks like there's pus going on. And when I touch it, it moves. It mobile. So why? Why does that happen? Is the implant fail? Or is it because the screw is starting to loosen? So let's test a little bit. So if the implant fails, if you hand torque it, it will mobile. It will twist and turn and it will come loose. If that happens, we will proceed with that later on. We'll save it for later. Now, if the screw loosening, if you hand torque, it will not mobile. So what you want to see, what would you like to do is you have to check the occlusion. You probably see that my tooth is pretty short already because I want it to be off the occlusion. I want it to be off the occlusion. That's why it's short. But it's not enough for the patients. So we tighten it, we check the occlusion, triple check it again, make sure nothing touch. And then 1 month later on, tissue looks nice, neat. Seems like nothing happened. But if this situation happened, rest in peace. If the tooth come out, the two options that you can do. One is you can go back to your preservation, clean the site, make sure no infection happen, and graft again. Or you can do like Dr. Lam, you can go with early implant placement with simultaneous GBR. Now sometimes not only the movement of the prosthesis or the implant happen, sometimes this happen as well because immediate implant placement, you have to put soft tissue graft, and sometimes graft do necrosis. And according to the literature by team from Dr. Kam, approximately 20%, so 1/5 of your case that you put soft tissue graft will have necrosis. For example, this case, there's soft tissue necrosis because part of the soft tissue is not fully covered inside the tissue. If you take a look, you can see that soft tissue, the top part has necrosis, but the bottom part still looks fresh, looks nice, because part that's not immersed in the soft tissue necrosed, there's no blood supply. So make sure that your graft is inside the soft tissue. There are a couple of ways that you can prevent it. One is make sure that your split thickness flap, your tunnel, has tension free. Or you can even put a suture to make sure that the soft tissue is in place. And one other thing is that you have to have a concave emergent profile. Have some space for your soft tissue to sit in, not to make it bulky, otherwise it's gonna push everything off. Now, go back a little bit. Remember I mentioned that if you put a bone graft and soft tissue graft, you have 6% that you have recession. But if your soft tissue graft died, then the chance of recession increased up to 30%. So what do we do? What do we do if the soft tissue got actually recessed? Take a look at this case. This gentleman got immediate implant placement done, and for a couple of years later, there was a recession. So what would you like to do first is make sure that your emergent profile is at the correct place. The emergent profile is not too bulky, have some concavity. Make sure that it's similar to the adjacent tooth or where you plan them to be. Then wait until the soft tissue mature. Then you can come back, do a soft tissue graft. This was a soft tissue harvest from tuberosity, and then we do a little tunneling. Then the solution can be fixed. Now back to our case again. We have this is 1 month after surgery. Then we wait up to 3 months before you actually move on. At 3 months, implant is steady, everything's go according to the plan. We try to put a mock-up on the number 11 to see how the patients look. We mold the soft tissue a little bit. And then, unfortunately, because of the COVID situation, we have to postpone almost everything. And then yesterday, actually, patients just come back yesterday with this. We did some adjustment on the provisional to make the shape looks a little bit better. At 8 months, the soft tissue looked very, very stable at this point. So we decided to move on with our final prosthesis. We do a customized impression coping, finalize the preparations on the adjacent tooth, and we did impression. Now, when we sent our case to the lab, we have two options. Is it going to be screw retain? Is it going to be a cement retain? Now, with this case, just like Dr. Melissa said, most of the case for immediates, there's a class 1 root sagittal. So, similar to this case, it's a class 1 root sagittal. That's why the screw axis come to the incisal edge. If I try to do a screw retain at this point, when I plan, there will need no bone for me to engage. So, but all of you know that screw chain has much more advantage. There's no cementing involved. You can do retrievability. So with this case, we decided to go for variable-based angulated solution. Some of you don't know that normally with a screw, it only goes straight. But with the AS, you can angle your screw and access it from your palatal. So you don't have to run with compromising with the aesthetics. Just similar to this case, where the provisional, the access hole running at the incisal edges, we use a definitive abutment with AS variable base, and the access hole move to the palatal. So that is our next plan for the patient right now. But unfortunately, because of the COVID situation, we couldn't finish the case, and that is where we are right now. So thank you from me and Pierrette again, and I hope everybody's safe with COVID, and I'll pass the mic back to you, Dr. Yip.
Thank you, Dr. Pranay. So that was an immediate implant placement that you have done, huh? So
I hope that I shift the whole toward me. I hope.
We will see, huh? We will wait for the Q&A. I think we move on here because we are just slightly behind time. So is watching, are you ready to, you are the periodontist here, so we're going to get some opinion from you watching.
Can I share the screen?
Yes.
Yeah.
Stop sharing.
Yep. So she is watching, Dr. Tan watching is the periodontist, and she's going to give us some tips on implant maintenance and follow-up.
Okay, so I believe that everyone knows that osteointegration is no longer a miracle because it's readily, easily done, and like you have so many people who are able to keep the implants. However, the longevity of the implant is what we are looking for. The patients will usually ask us, how long does it last? Does it last 5 years, 10 years, or more? Can it be forever? So those are the questions that we always get from patients. So there are a few prerequisites to ensure implant longevity. Through research, we have found that important thing is the oral hygiene of the patient. Now, of course, if the patient do have existing periodontal disease, you need to treat that first because that increases the risk factor. Now, of course, smoking also increases the risk of implant failure. And to have a cleansable reconstruction, so like Chai and OB and everyone should be giving us a cleansable reconstruction that the patient could clean. And of course, close monitoring of the implants. And one very important thing that is gaining popularity or gaining recognition now is maintenance, which is what periodontist is all about, right? Okay, so why do we do implant maintenance? Because to me, this is actually part of the treatment of implant treatment. It does not end when you place the implant or the crown. It is a continuation, it's the beginning. It's just like a marriage. When you marry, it's not the end, it is the beginning. So when you have your implant placed and your crown placed, it's the beginning of a relationship with your patient, where you need to maintain the implant for life. This is to actually prevent or keep the infection of the implant and allow longevity of the implant for long term. Do I have evidence for that? Yes, I do. So this is a study that is recently been accepted in clinical oral implant research. It is a collaboration with my colleagues in the National Dental Center. And we gathered 200 subjects, and of which 100 of them were maintained in National Dental Center, and the other 100 went back to the private dentist for maintenance for various reasons, because they are referred into NDC for treatment. And the follow-up of these patients was about almost 7 years. And we found that when you have a regular and a defined maintenance program, the risk of peri-implantitis is really low. It is about 6% in a patient level. So for us, the patient level is really important because it's all about patient. It's not about the number of implants. So if it's not well maintained, it's about 1/5 of the patient will have periimplantitis. That means bone loss and bleeding and needing some form of intervention. So based on this study, we concluded that regular periodontal maintenance is very important to reduce the prevalence of periimplantitis and peri-implant bone loss. And this is for a mixture of patients with both perio as well as healthy periodontal patients. How about periodontal patients? So this is an earlier study which I did with my team again in the National Dental Center, and this is of a smaller group of patients, of which we find that if you have a periodontally susceptible patient who has undergone treatment and has attained health, once you place implant in them, if you do have a vigorous follow-up with them, they perform just as well as a patient who is periodontally healthy. So for us, to me, that's good news. So to me, maintenance is like driving a fast car. Rather than you allow it to break down when you're trying to speed up, you should maintain it so that you have the performance of the car. So it's the performance of the implant long term for you and your patient. And of course, it improves your, you're known that your implant stays for life for the patient per se. So what does implant maintenance involve? Does it involve a lot of things? Do we need to have 3D planning and stuff like that? No, actually for me, implant maintenance, it's something very simple. You probably just need a mouth mirror, which you have in your practice. You need a periodontal probe, which doesn't cost too much. And it's important that this all starts before you maintain the patient. So once you have the prosthesis, you need to ensure that you have a baseline data. You have a baseline of the probing depth, the bleeding probing, and radiographs. The reason for that is because sometimes when we have aesthetic cases, we tend to sink the implant deeper, and especially in cases where we do immediate, the placement of the implant is again more apical. So if we do not have the baseline data, we may think that, there's bone loss, but actually it was the probing that was there all along the baseline. So it's important to have baseline data. And following that, we will be able to prescribe the treatment and to plan the regular recalls for the patient. So for a routine patient with no issues, I'll see them every 6 months. For periodontally involved patients who have risk of periodontal breakdown, I tend to see them about 3 to 4 months, depending. And also depending on the performance of the implant. So like I said, it's important that you have the probe, and you can either use the normal UNC metal probe, or some people like the fancy plastic probe. You can actually use that too. And it's important to monitor if there's any bleeding on probing, because that will tell us if there's any mucositis. Okay, and then it's important to have good radiographs as well. This is a good radiograph because you can actually see the threads and also the bone level. And you can take this routinely, yearly, or once every 2 years, depending on your patients. So there are many times when we take radiographs and we can't even see the threads, and those are rather useless for our diagnosis of the crestal bone level. So these are the simple things that we can do during our maintenance. Sorry, my slide's not advancing. Okay, I guess I'll just run through what we do, because my slide is not moving. So I'll just run through what we do. So when we do the normal clean, if the patient has mucositis or just plaque around the implant, what we usually do is we'll use a non-metal curette. You can actually use they have a special hand instruments for implant cleaning. It can be either graphite ones, carbon ones, or I tend to use the titanium ones. And also you can use rubber cups. And there are also those that you can fix onto EMS, like with PIC material, or if you use a Cavitron, they have those with a plastic tip which you can use to remove the calculus of the patient. I have pictures of that, but because my slide is not advancing, so yeah. So these are simple things you can do, and there are a lot of things you can based on what you see in the patient, but I'm just talking about just mainly if regular maintenance, if the patient have mucositis, peri-implant mucositis, what do you do? So it's basically the usual things you do, except that you do not use a metal instrument. You use not the usual stainless steel instrument for cleaning, because you tend to scratch the implant, but you use the titanium ones or the graphite ones. Yeah, so yes, all to you, Kim.
Yes, thank you for watching.
Sorry, because
Can
my...
you stop your share screen? Yeah. Are you stopping your share screen?
No, something is, my thing is not working.
Uh-huh.
Yeah, it's
Okay.
stuck. Okay. Yeah.
Okay. Thank you. Very interesting. I think they picked the right person to talk about maintenance and follow-up. But unfortunately, we can't see the last few slides of yours, which is very interesting to know. But we will then now, right now we have, yes, we have finished all the presentations. Okay. So, all right, we have all the panelists here. Shall we now go to the Q&A session now? Now, let's start with the case that was presented by Dr. Piyana. Are there any questions that the panelists would like to ask her on the case?
Yes, there's some questions in the Q&A box. Yip, you can open it up and you can pick some questions. For example, Obi, for the customized impression coping, what material would you suggest on using?
Yes. So traditionally, when I was doing my residency, I used to use resin, do it in indirect technique. However, I feel like it takes longer times in that way. Now, normally what I did was using a composite resin. Let me actually show you the slides. This is what I normally use right now. I just use composite resin and use flowable to capture the emergent profile. The emergent profile that I usually get is similar to something like this. We only capture the important part, which is the critical zone. Oh, the slide's not showing. It's open here. It's better? All right. So it shows, let me go back a little bit then. So I use composite resin right now, and then we usually capture the, it has to be very, very quick though. You can't just take the provisional off and just walk around. You have to do it right away. You want to be able to capture the critical zone of your provisional, which is 1 to 2 millimeter, the first 1 to 2 millimeters from your gingival margin. The critical zone is not very important in terms of dictating the aesthetics if you're placing the implant at the correct position. And this is what usually the final outcome looks like.
So,
Answer the question.
Obi,
Yes.
you hear me?
Yes, I can hear you.
Yeah. So may I ask you if you use flowable composite? Is there any difference if you inject directly the impression material in this? Because for flowable, you need a time for the material to be harder, right? So anyway, I don't see any difference if you inject the flowable composite instead of you inject the impression material. So can you explain?
That's true. Sometimes I do use the impression material like PVS light body first, and then once it's set, we can use like medium or heavy body on the impression post. The PVS material do adhere to each other. I don't have good evidence of does it make difference between you use light body or resin material.
Well, I might add for Dr. Pranay a little bit. Yes, of course, you can inject light body or medium body directly into the sulcus that you form. The problem is, number one, remember that polyvinyl siloxane don't like water, is hydrophobic. Okay, so sometimes it's not going as far as we want it to be. Number two is, it takes 5 to 6 minutes for it to completely set. Comparing to if you use the flowable resin composite and you light kill it right away. Okay, so now it depends on how fast the tissue collapse. Well, from my experience, it's quite different in each patient, because sometimes you remove the healing abutment and you put the impression coping in, or maybe you just remove the healing abutment and then you try to put the healing abutment back on, and patient feel pain. Because some patient the tissue collapse really quick, but in some situation it didn't collapse that fast. Okay, so if you ask me, I would still prefer to use the light kill resin composite, because that we can control the setting very quickly, better than the PVS material. That's my preference.
Yeah, understand, because usually we use the indirect way. We copy the provisional.
Yeah.
And then we use the strip material like pattern resin or something to copy. But now, yeah, I agree. So you interact directly the flowable composite in the socket.
Yep.
Yeah. It's faster. Okay. Yeah, but yeah, of course, it depends on the collapse of the soft tissue. Agree.
Okay. All right. So we have another question for Washing. What are your hygiene instruction and in-home maintenance protocol that you provide for your implant patients? Washing.
It's still regular brushing, and I introduce interdental aids, either dental floss or the interdental brushes. The other thing is the maintenance protocol. It all depends, like I mentioned before. It all depends on the patient's risk factor. So if the patient has minimal gum problem and it's just a regular patient, the implants seems fine with minimal probing, minimal bleeding, I see them 6 monthly. But for patients higher risk, they could be periodontally susceptible patients, I tend to see them closer, like 3 to 4 months. And smokers, I tend to see them a bit closer as well. And of course, patients who have increased probing depth over time, I tend to see them on a closer interval as well. I hope that answered the question.
Okay, 3 more questions. Actually, this one is quite a long time ago. For this case, there is a significant vertical soft tissue deficiency. Any plan for soft tissue augmentation? I think Obi already did answer this question with the connective tissue graft. All right, so I will dismiss these questions. What kind of material do you plan for restoration, Dr. Pranay?
So the plan for final restoration is zirconia, but however, for the aesthetics purpose, we'll do the layering on the label surface.
Okay, all right. So I think that answered the questions. The last one is there any consideration for the length of the dental implant? Are there any issue with longer implant, like 15 millimeters or more? Marcella, can you answer this question for us, please?
Yes, actually, the implant we need or we see first, if the palatal bones is quite a lot, not really necessary the very long implant. 3 to 4 millimeters engaged to the palatal side is enough. No need like very long bone. Previously, I used a lot of long implant, but actually right now not really needed. Just to engage it to apical, that's enough. We get the prominent stability.
Okay, all right. So I think that answered the questions. So that's all from the Q&A box. Dr. Yip, microphone is yours.
Yes. Can I ask the panelists?
Yes, you can.
Can any of the panelists pose any questions to?
Okay, questions.
Yes, Marcella has a question.
Yes, to Obi, did you do a mini flap when you insert the connective? Did you use connective tissue graft from palatal or tuberosity? Well, if you use any of them, did you make mini flaps so you can insert it in? the connective tissue graft?
Yes, Dr. Mas, that's very good questions. My sorry. So my to-go list to go to for grafting for donor sites actually from tuberosity. But however, not every patients have tuberosity tissue. So for this case, unfortunately, patient doesn't have it. So we have to take it from lateral pallets. As for delivering the inserting of the soft tissue graft, I actually do a tunneling on the label surface. I actually doing like a coronal advancing for during the suturing. So I make a little bigger tunneling to the adjacent tooth a little bit, so I would be able to maneuver the flap to the coronal portions.
Okay, you place the CTG after you fill in the gap, or maybe before?
I actually put the bone graft first, because the reason was I normally do the tunneling after I put the bone graft. I'm actually afraid that if I do the tunneling without bone graft to support, my buccal bone might collapse or broke down. That's why. So I like to at least have some cushion, have some bones in the socket first.
All right. Okay, Dr. Yi, please.
Yeah, may I have a question for Dr. Piraya?
Yeah.
Yeah. So when you presented the case, you say that there's no parafunctional habit, right? But we observe the case closely. We can see some worn surface, or the true canine, because it's very short. And how do you explain that? And do you have any special occlusal treatment for this patient, or when you adjust the occlusal for the final graft? Thank you.
I think I have planned after the implant placement is finished, I have sent to the patients to the TMD specialist to evaluate and the parafunctional habits of these patients. Maybe this patient has a nocturnal parafunctional habits because we can see the tooth wear on the inside edge of the lower anterior teeth, and some of the molar has some other wear on that. And closely recall of the patients.
Okay.
Does that answer your question?
Yes, thank you.
Yeah.
Can I ask a question?
Yes, watching.
I might have missed it, but can I just check when after you extract the tooth, was there any buccal wall?
No.
There was a deep narrow defect. There was still a buccal wall. It doesn't show on the X-rays, but there is.
So was there a dehiscent at all, or it's just there's a thin wall all around?
It's a thin wall with the dehiscent on the distal buccal.
Okay. So was there any what do you do for that slight missing wall? Is there anything special you do, or it's usually the same?
It's usually the same with if it's a V-shaped defect. Yes.
So it's just the bone graft and then CT graft.
Yes, but if it's like a U shape or ultra U, then we'll consider do either a flap or change it to early or late implant placement.
Okay. Thank you.
Okay, Obi.
Yes.
Dr. Pranay, I would like to find out from you. I understand this is COVID situation and you only reviewed the patient at 8 months. Now, how long do you wait from the stage from your extraction stage to the provisional stage and do your final restoration in a normal situation in your immediate placement option?
So that's a very good question. Normally, I only wait 3 to 4 months after the surgery to move on to the final stage. Now, however, with this patient, we actually have to put a veneers on the number 1-1. So we try to recontour the soft tissue by putting a composite fillings there first to reshape the soft tissue before we actually move on. We were planning to wait additional 1 more month for the soft tissue to actually be in shape before we actually do the impression. However, because of the COVID situation, that's why right now it's 8 months.
So on the average, it's about 3 to 4 months, and then you will finish with the final restoration.
Yes, sir.
So let me just compare your immediate placement and an early implant placement. So in an early implant placement, post-extractions, it's 4 to 6 weeks, followed with an implant placed, and you wait for the osseointegration to happen. So Lam, how long do you wait to restore your early implant placement?
Yeah, I think it's quite the same. It means we wait from 4 to 6 weeks after extraction, and then I place implant with the GPR simultaneously. And then usually I wait a little bit 3 months before the second phase of healing and provisional phase. And from that point, it will be the same like immediate placement. But for the patient or for the clinician, skill is very easy because we don't need to take the soft tissue graft because we have the natural soft tissue graft. After 4 weeks or 6 weeks, you have very thick of soft tissue, so no need to make another soft tissue graft painful for the patient. But of course, a bit longer. But I think for the mid-facial recession, Professor Buzer and his team have shown that the early placement approach it showed the best result in terms of mid-facial recession in compared to immediate placement or delay placement. Yeah, it's my opinion. Yeah.
Okay, that's good. So in other words, if I may say, on the average, between an immediate placement with the provisional IPP versus an early implant placement, is it correct to say that the total treatment time on the average between the two options are almost the same?
For my opinion, it's actually no, because you still have more time for your provisional or soft tissue molding, which sometimes it takes 3 months up to 6 months in order to get that interdental papilla back. It's very hard, in my experience.
Mm-hmm. I believe so. Just based on what Marcella and Dr. Pranay, as well as maybe even Dr. Lam was talking a bit about immediate placement. I think I would like to just make a comment that immediate placement, like Professor Buzer had said, should be handled in the hands of a very experienced clinician. Because as you have seen in today's webinar, the procedures that have been elaborated by our colleagues here, our panelists here, they are highly technical. And I hope you will agree with me. From the point of placing your implant in an immediate situation, and then to place your soft tissue graft, and then followed with a immediate provisional, and the amount of skills, knowledge, and experience are probably in a complex level. So I think Professor Buzer has said before in one of his presentations that this particular option should be in the hands of a very experienced, highly trained, highly knowledgeable, not just in implant placement, but also in the materials, prosthetic materials, in provisional materials as well. Okay, are there any other comments?
No more comment. They are right.
I would like to ask watching. Yes.
What would you like to ask?
Yes, in a delayed placement, number one, what sort of grafting materials would you use in a delayed placement?
Delayed placement.
In delayed, ridge preservation, whether it is an open flap or a flapless, what grafting material is would you consider?
I usually use a xenograph.
Xenografts. What is your opinion of this material ethos? Have you heard of it before?
No, not really. Maybe you could tell me.
ETHOS. I think it's or if I'm not mistaken, it is it may be an allograft, and it is combined with some hydroxyapatite. So you have no experience with it. Okay, fine. I think that was one material that one of my colleagues mentioned. So, are there any of these panelists here have an experience with this material? No. Okay. My next question to watching is, I noticed that after 6 months, you lift up the flap to look at your grafted bone.
Yes.
Could you tell me why you lift up the flap and not do a flapless procedure after 6 months?
I will still lift up a flap, but I would say that now I probably will not lift up such a big flap. That was more for a photo effect, you know, to see the.
To see, out of curiosity, huh? Okay.
I mean, I wouldn't have lifted such a big flap now. Yes.
Yes. We have a participant who posted and said ethos is an alloplastic material, beta top and with calcium sulfate. I think the calcium sulfate is the thing that binds the alloplastic material together, I think. Well, there is not enough experience to be shared in this forum here. I would like to just, yeah.
I have to say, but if you look at one of the studies by Rona Yong, but it may not be the same brand, it's another brand, also beta TCP, it shows that it actually has more resorption.
Yes, I agree. I agree. Beta TCP is gone very quick.
Yes. So TCP is tricalcium phosphate. Huh?
But it's not the same product, I think. The one that he uses is a different product, but it's the same like beta TCP.
Okay. All
Well,
right.
I'm sorry, I'm not promoting the product. I think his study actually he shows that it's worse than normal extraction because it dissolves very fast.
Okay. I think I recently attended a webinar by Professor Boozer, and I just share this with you. I think one point that Professor Boozer mentioned, maybe in this particular case, that he actually did a socket. He recommended a ridge preservation, and followed 4 months later, and he will use a computer-guided technique to place the implant with a flapless procedure, especially for an elderly patient. Okay, that is to minimize all the surgical procedures. So yes, I think we have a very fruitful discussion here, very interesting. I like to maybe close this webinar. We have already passed almost 2 hours now.